The purpose of this video is to demonstrate the surgical technique of a close reduction and percutaneous pinning under fluoroscopic guidance of a displaced pediatric extensile type supracondylar humerus fracture. The patient in this case was an 8-year-old male with a right supracondylar humerus fracture type 3. The patient was playing outside with friends when he tripped and landed on an outstretched arm. He felt immediate pain localized to his elbow. Upon presentation, the elbow had obvious deformity and swelling, however, it was neurovascularly intact. Imaging revealed a complete transverse, displaced, extension type, extra-articular, supracondylar humerus fracture. Indication for surgery in this case was that the fracture was displaced and unstable in a pediatric patient. The planned procedure was a closed reduction, first including traction, hyperflexion, and a combination of pronation and supination to guide the epiphyseal fragment back into alignment and subsequent percutaneous pin. The patient was positioned supine and Kirschner wires size 0.062 inch diameter were utilized. This portion of the video shows the closed reduction maneuver used to achieve anatomic alignment. The arm is manipulated as a unit, rotating the arm to get good lateral x-rays. Additionally, this portion demonstrates the room setup. We try to position the room so the surgeon can operate comfortably. The elbow is usually positioned at waist height, and the fluoroscopic image can be viewed without rotating one's body too much. In this particular video, fluoroscopy comes in at the head and images are displayed at eye level of the surgeon with the surgeon standing at a comfortable height. Additionally, for safety reasons, it's also important to minimize radiation for the patient and others in the room whenever possible. Here is the placement of the first percutaneous pin, driven obliquely across the fracture site from laterally to medially and distally to proximally. We chose to use a lateral pin construct. Our goal was to use 2 to 3 divergent pins with spacing to provide stability and avoid a medial pin if possible. The pin is driven into the humerus with power and intermittently driven using oscillation, as this produces less thermal energy. This is the placement of the second percutaneous pin. After placement of the second pin, we check anatomic stability under fluoroscopy. Here we are checking stability of full flexion and extension under fluoroscopy. Subsequently, the third percutaneous pin is added. Ideally, we would like these pins to be more divergent and more proximal at the fracture site. They are too low and cross. The entire arm is subsequently checked under live thoracoscopy to ensure stability. This is the video of the live fluoroscopy demonstrating stability during full flexion and extension in the AP and lateral views after the 3 percutaneous pins were placed. All 3 pins are bent over to minimize risk of internal migration and are subsequently cut outside of the skin. After cutting the pins outside of the skin, stability and reduction are rechecked using imaging to ensure the fracture did not displace. After cutting the pins and rechecking stability, zeroform is looped around the bent edges to provide some cushion and protection with a non-adherent covering. Afterwards, the pins are covered with sterile gauze. It is important to note that after pinning and before dressing, swelling and circulation were evaluated. The patient's compartments remained soft and circulation was healthy throughout the procedure. Once covered with sterile gauze, web roll is added for a well-padded splint. The splint created for the patient consisted of 3 slabs of plaster. 1 slab is run along the length of the dorsal aspect of the entire right arm. Additional slabs are placed on the medial and lateral edges of the patient's bent elbow in order to optimize support. The slabs are then covered with web roll, and finally an ACE bandage is wrapped, completing the splint. With these 3 pins, we felt stability was achieved satisfactorily based upon the live stress images. Subsequent images confirmed healing in good alignment with no loss of reduction. Optimal pin position, including direction and number, has been studied. 3 pins were used in this case, and these pins did lack divergence or spread, which may compromise the biomechanical strength of the construct and an increased risk of loss of reduction. Better pin divergence from these 3 lateral column pins or adding a medial pin can increase stability of the fixation.